Good evening, everybody. We're going to start in a couple minutes. Just please be aware to mute your line so we don't get any background noise, and we'll be starting in a few minutes. Thank you. All right, Drew, you ready?
I'm ready.
Okay, good. Thank you all for coming this evening. My name is Tony Caparelli. I'm the Director of Product Management at X-Cel Specialty Contacts. Thanks for joining us on this Tuesday evening, taking time out of your day. We appreciate it. We're going to talk tonight about scleral alternatives for post-refractive corneas. We feel this is an important subject. As we've seen sclerals really become so popular, we have many offices that rely on only sclerals to solve the problems of these irregular corneas, and in particular post-refractive corneas, but we have many options as a specialty contact lens lab. So tonight we have Dr. Drew Biondo, who's in private practice in St. Louis, Missouri. And Drew fits a wide variety of specialty contact lenses, but his focus is on scleral lenses for patients with keratoconus, severe dry eye disease, and other corneal abnormalities. Drew is also specialized in the treatment of severe dry eye syndrome related to systemic disease, namely graft versus host disease. And he's helped pioneer the use of amniotic membrane transplantation by optometrists in Missouri. He's the president-elect of the St. Louis Optometric Society, as well as a member of the Missouri Optometric Association, the American Academy of Optometry, the AOA, and he's a fellow of the Scleral Lens Education Society. He is also an adjunct clinical professor for the University of Missouri, St. Louis College of Optometry, and he lectures nationally on scleral lens fitting and practice management. So welcome, Drew. Please hold your questions for the end, and you can either type those in, or we'll unmute you and let you speak at that point. Drew, it's all yours.
Thanks, Tony, and thank you everybody for coming out tonight. We actually did this lecture at one of the side sessions down at GSLS a couple months ago down in Vegas, and it got some good reviews and some good feedback. So we decided that a webinar would be a good way to share this with everyone. So it's a good topic because there's a lot of reasons we don't fit sclerals. Even if you're somebody like me and a lot of us now who absolutely love scleral lenses, there's always reasons to have more tools in the tool bag and more weapons at our disposal. So a couple quick disclosures here. I'd be remiss if I didn't at least just quickly mention the reverse geometry design in the Atlantis Scleral. So if you are fitting Sclerals, they obviously do make great options for any kind of post-refractive or post-surgical cornea. And the Atlantis is no exception to that. The Atlantis has something that's called a 3D vault zone. The 3D vault zone is a reverse geometry design that allows for the tenting of the mid-periphery in 3 increments, 100, 150, and 200 microns. So you would specify simply 3D1, 3D2, or 3D3, and then you would get 100, 150, and 200 microns respectively. It's easy enough to do. It doesn't involve the central vault at all. So the reason we run into issues with Sclerals is because we want that 200 microns of central vault. On a oblate cornea, a plateau-shaped cornea, if we maintain that 200 microns of vault centrally, as we get close to the edge of the treatment zone, we can run out of vault and have touch. And that can create irritation, discomfort, can create seal off in some cases. And so reverse geometry designs minimize that. And this allows an independent vaulting of that mid-peripheral cornea, which is very cool. What makes it even better is it goes a step further. Not only does it allow us to vault up to 200 microns in that mid-periphery independently, it allows us to specify where we want that vault to be located. So we can have that vault in near the central zone, and near the optic zone, in the in position. We can have it in the center of the mid-periphery in the standard position, or we can move it out toward the edge in the out position in kind of a paralimbal type position out there. I find the standard and the in work really well for oblate corneas. Typical treatment zones, 8 to 9 millimeters these days. And with our central zone being about 8 millimeters, just outside of that is where we hit that edge of that plateau, where the steepening occurs on those corneas. So being able to vault up in those areas can be very beneficial. Out works really good. I know it's not a post-refractive cornea or a post-surgical cornea, but it works really good for PMD, where we have a lot of limbal elevation. We tend to use that out position a lot for our PMD patients. Or if you see the Salzmann's nodules that pop up toward the limbus, that's a really great design as well. The in position works really good for post-PK patients as well, where the host and graft junction occurs. So you can get these lenses an adjunct to your Atlantis fit set, and they're laser marked with the in, standard, and out position. So you just see where your area of touch is, and you can use these rings to specify where you want that additional elevation, where you want that reverse geometry to tent up and miss those obstacles. So I promise that's all I have on Sclerals. We'll now get to what we kind of promised, which are the 2 scleral lens alternatives that X-Cel offers. And there's a lot of reasons to not use Sclerals. As great as they are, and as many patients as they've helped, there are plenty of patients out there who would benefit and get just as much advantage out of custom soft lens designs. That's what we'll kind of talk about. And why would we avoid Sclerals? Cost is a big issue with Sclerals. Sclerals cost a few $1,000s. And it's not just that people can't afford Sclerals. It's that a lot of people don't maybe want to invest the money in Sclerals for a problem that's not worth a couple $1,000s. I always give the example. I've got a young female patient. She came in, this was about a year ago, and she came in. She'd had LASIK about 4 years prior. She was a very, very mild amount of myopic regression, maybe a -50, -75 with a touch of cylinder. But she had been to a number of places, and they could not fit a standard soft lens on her. It would just decenter automatically. It would bounce all over the place, and she couldn't get off-the-shelf bioaffinity type soft lens to center on her oblate cornea. She's happened to be married to a professional athlete. She had all the money in the world, but she just needed a little bit of improved vision for athletic activities like tennis. She could see great out of spectacles. She saw good the majority of the day, 20/30, 20/25 vision. Just wanted something that she could throw in to play tennis, to go to a baseball game. And so while cost wasn't an issue from I can't afford this standpoint, it was an unnecessary cost to put her into a scleral design, even though she would have done great with it. The hassle and expense of a scleral lens wasn't justified in this example. And so the first lens we'll talk about, we put her in, and she's really excelled in it. Insertion removal can be a barrier to some patients in scleral lenses. First-time contact lens wearers can have a little bit of an issue with scleral lens insertion. People with Parkinson's or other dexterity issues can struggle with filling the lens with saline, spreading the lids, inserting the lens. that can be a little bit of a difficulty for some patients. And then some patients just are apprehensive about a large rigid lens. And even though we can educate them all day long about the advantages and the comfort, they still don't feel comfortable with the idea. And on the other side of that, a lot of practitioners don't feel comfortable with scleral lenses. Soft lenses are in our wheelhouse. We all know how to fit those. We all know how to evaluate those. We know to some degree what the comfort will be like with those. So if we can get those to fit properly, a lot of us will be more comfortable fitting the soft lens and making the jump into scleral lens designs, especially for maybe patients that don't need a rigid lens. Morphology limitations of scleral lenses are out there. You know, pterygium and pingueculas have always been kind of the scourge of the scleral lens community. We can use things like notching and microvaults, but they come with limitations and they come with difficulties. If you can just use a soft lens, get the same visual outcome, and just drape over those peripheral obstacles, you know, it might be a good option for a number of patients, especially ones that struggle with redness and irritation out in the periphery. Glaucoma patients, especially those with filtering blebs. Blebs I get pretty nervous about with scleral lenses, although you can notch around them successfully. Tubes I don't worry about as much. I just make sure to use toric haptics and make sure I'm not impinging too much. Those tubes aren't going to collapse under the weight of a scleral lens, but you can erode the conjunctiva and sclera off the top of those tubes, which can leave the eye susceptible to infection. So you do have to be careful with those, even though I have a lot of patients with filtering tubes and scleral lenses. But again, if we can simply put a soft lens on these patients, it can work great. And then finally, there's some new data coming out that's not by any means conclusive, but is leaning toward the idea that scleral lenses can increase intraocular pressure by decreasing that episcleral venous outflow. You know, we're compressing the veins where that aqueous is essentially leaving the eye, and that might be causing pressure increases. And there's some good studies going on with transpalpebral tonometry over the top of scleral lenses that initially have shown some pressure increases. Now, I don't worry about this in the average patient, and we've been fitting Sclerals for over a decade now without any sharp increases in glaucoma. But if I have a patient with a few ganglion cells left who's barely hanging on all the drops and tubes in the world, I might think against putting a scleral lens on that patient. Even if they're irregular, a lot of these patients have other things going on, like corneal transplants that need irregular corneal lenses, but scleral lens might not be the best option if they're highly vulnerable glaucoma patients. So again, custom soft can be a good option in those cases. So we'll start by talking about probably my favorite lens outside of scleral lenses to fit, because it's very easy, very rewarding, and can be very profitable too, which is always a plus. It's the FlexLens PRS, and PRS stands for post-refractive surgery lens. It's essentially an oblate or reverse geometry designed soft lens. So it's a soft lens that's custom made. It's lathed, so it's cut like a GP, and then it's hydrated into a soft lens overnight. And it's very customizable. You can really get specific in base curve, diameter, power, plus to minus 30. It's crazy. I find from a fit standpoint, we'll talk about how to fit this lens tonight. I think there's either 7 or 8 lenses in the fit set. And I don't think I've ever ordered a parameter, maybe a diameter change, but outside of the base curve and diameter within that fit set. So although you can get very customized with it, it's very easy to fit out of the fit set. And I love the fact that it comes in a fit set. That can be cumbersome and add some chair time, but I love the idea that a patient can feel what this lens feels like on the eye before I order it. I know what the vision is going to be and what the fit is going to be before I order it. And it's a very efficient fitting process. So I'd rather try something on and know what the outcome is going to be rather than order an empirical lens for an irregular cornea and hope that it works, and more likely than not have it work and waste both mine and my patient's time with that lens. So again, it actually has a reverse geometry design, a reverse curve built in to the soft lens. It helps it center over an oblate cornea. Comes standard in a 15 millimeter design. Like I said, they have, it's either 7 or 8 base curves in the fit set. And that's all you do to adjust the fit of this lens, is either steepen or flatten the base curves. Very, very simple. There's some tools to help you decide on initial lens selection. So pre-op K range can help, but we so rarely know what pre-op Ks are in a lot of these LASIK patients. I almost never use that side. Post-op K range will give us a good starting point as far as which base curve we choose based on the flat K. Or if you're in doubt or you have a lot of irregularity, just start with the 8-7 base curve. It's the one I end up using the most. It's relatively flat, which is good because these do tighten up throughout the day, and we do need tear exchange under these lenses. They're a little bit thicker. They're not sci-high materials, so a touch of tear exchange is all you need to get great oxygen to the cornea, but we do need that tear exchange. So start with an 8-7, and evaluating this lens is super easy. We all know how a soft lens is supposed to fit, and all you're doing is making sure it fits like a soft lens that you know how to fit. So the two big things you look for initially is you put the lens in and you see, is it laying flat all the way around? In other words, is the edge of the lens laying flat against the conjunctiva? If it's fluting or lifting, you move on to the next steeper base curve in the set. You also look for centration. Is it centered like a soft lens should be centered? Is it sitting in the middle of the eye? And if it's not and it's moving all over the place again, you simply just keep steepening the base curve step by step until you get centration and no edge lift 360 degrees. I like to have the patients look left, right, up and down and look for edge lift in any quadrant. And if I see it right away, I'll just go ahead and steepen that base curve. So from there, you let it settle. And it's important to let this lens settle. The fit guide will tell you 30 minutes. I'll tell you at least 15 minutes before you do your push-up test, because you really want to make sure this lens doesn't tighten up too much, again, because that'll cause decreased comfort and oxygen later in the day. But let it settle for 15 minutes. And I've got a video of this on the next slide. But it's very simple. You're just going to do that old push-up test that they taught you back in optometry school that you thought you would never use. You take 6 o'clock on the lens and you push it up to the limbus, and then you let it fall back. And you want to see two things. One, can you push it up? You want to make sure if it resists that push-up test, it's too tight, and you want to move to the next flatter base curve. If you can push it up, you let it go. Does it fall back and center itself? If it does, you're done. If it doesn't, if it stays up top or it moves all over, you need to tighten that base curve a little more. And this is all written in the fit guide that comes with the lens. So I'm just basically reciting that. It's very, very simple. If you get resistance, you flatten the base curve. It stays superior or the edge lifts off, you steepen the base curve, falls back to center, you're done on that push-up test. And if you look at the next slide here, this should play. This will kind of show you. We're just going to push that lens up to 6 o'clock. It'll fall directly back centered. And then we'll have their look into primary gaze. You'll see that lens is nicely centered on the eye. Again, really easy to fit, really efficient to fit. We can play that one more time. With only 7 lenses in your set, it doesn't take you long to find one that sits on there properly. And most of the time, the lens that you select will be the one you end up with after the push-up test. But it's an easy way to make sure this lens is going to center properly. This lens only comes in as a sphere. You cannot get toricity with this lens. If you need toricity, you'll move on to the next lens in our set, which is the flex lens arc. I know that sounds like it's very limiting, but in these oblate corneas, it really is very efficient. I'm sure a lot of you have noticed this. Whenever I have a post-LASIK patient that comes in, they had LASIK 5, 10, 15, 20 years ago, and you do your manifest refraction behind your phoropter, and you get $1.50, $2 diopters of SIL, and you go grab your soft toric out of your Air Optics Aqua set or whatever it is, and you put it on, and the hash mark's right at 6 o'clock, and it matches your manifest refraction, but they get a ton of ghosting. The optics just don't line up because that astigmatism you're getting is not regular. And you go grab a spherical equivalent lens, even though they have $1.50 of SIL, you put that on, and assuming it centers, the vision drops to 20/20 or whatever your best corrected acuity was. And that really holds true with these oblate and these post-LASIK, post-PRK, post-refractive corneas. You really can correct a lot of refractive SIL and corneal SIL with a spherical lens in oblate corneas. And I couldn't tell you the exact reason or the exact optical property behind that. I'm sure there's some people smarter than me that could, but it's amazing. I had not too long ago a patient with 5 diopters of SIL on his topography who was 20/20 with a spherical PRS lens. So it really does work well, and it leads to more efficiency as well. A couple quick things. Vision fluctuates. You can't increase that center thickness if it's kind of bunching up on you on the surface of the eye there. I always order this lens in the 49% material, which is a hydrogel material. It is offered in a sci-high. It does fit looser. It moves more. So you do steepen that a diopter to a diopter and a half over what you have in your fit set if you want to order in the 74%. Again, if you have tear exchange on an open blinking eye, I don't see the need for a sci-high in this lens, and you have more stable optic, I think, and definitely more stable material in a hydrogel lens. So that's it for the PRS lens. The next lens is the Flex Lens ARC, which stands for the atypical refractive correction. So this one is more for your post-LASIK ectasias, your really irregular corneas, your post-graft patients, your post-RK patients, more of your kind of train wrecks, more than just your oblate corneas. Oblates tend to really do well with that PRS lens. These arc lens is more for more severe irregularity. You know, it is still a soft lens, so I don't try to use it on really severe cones or really severe irregular astigmatism. It's good for your mild to moderate post-LASIK ectasias, your relatively normal post-graft patients. It can handle more than you think it can handle, but there are limits to what a soft lens can correct, obviously, in the realm of irregular corneas. The idea behind this lens is pretty simple. You fit the back surface, you fit a base curve, just like with the PRS lens. You adjust base curve steeper and flatter based on a few different things until you get a proper fit over the eye. And then the profile of the lens is thicker centrally, and that eats up a lot of irregularity. It helps to smooth out or cancel out a lot of the irregular surface. And then you have an independent front toric zone where you can clean up all of the residual prescription with a spherocil over refraction. It's prism ballasted, stabilizes very well. They all come with 1.5 diopters of prism. You can increase that. You will rarely need to if you fit it properly, which again is easy to do. Super customizable, pretty much any power, any diameter, and any base curve you want in very, very small increments. Axis is 1 degree around the clock. Cylinder up to -10 diopters. So it can really serve as a workhorse lens for A, those irregular cornea patients, B, just high sil patients. You know, patients who don't correct very well with glasses and high cylinder or looking for contact lens options in the soft lens realm. There was a study done initially when this lens was released. 59 eyes were fit. These are all irregular corneas. 42 of those eyes were 20/30 or better with that lens, which in the irregular cornea realm is very good. What I like about this study is it showed only a 30% exchange rate to get final outcomes with these contacts, and that's as good or better than any Scleral lens you'll find on the market. So that's pretty impressive. And again, that's because it's fit diagnostically with a very simple fitting system. You'll see there's 2 different thicknesses that it comes in. We'll talk about how to select that on the next slide. And you'll see with the irregular corneas, about 2/3 of them were in the thicker design. So the fit set, again, very simple. There's 9 base curves, and that's what we're going to adjust to get fit is the base curve. 9 base curves, but there's 18 lenses total, because in one side you have 9 base curves with a 0.3 millimeter center thickness, and on the other side you have 9 base curves with a 0.5 millimeter center thickness. And as you can imagine, the more irregularity we have, the thicker lens we're going to use to mask that irregularity. And so right over here, it'll kind of show us if you have, this is corneal cylinder. So if on your topography or your K readings, you see 2 diopters of sil or less, go ahead and start with 0.3 millimeter thickness. But if you have more than 2, which you will in a lot of these cases, go ahead with the 0.5 millimeter center thickness. As far as which base curve you start with, I tend to use mean K, so flat K plus steep K divided by 2, and then convert that to millimeters. That's the K I start with. But they also, according to the fit guide, there's another way which works pretty well. If your flat K is 49 or less, you go 8.3. Greater than 49, you go to your 7.7 base curve, and that's your starting point. When you see a steep cornea, you're going to want to jump to a steeper base curve. Again, just like with the other lens, these lenses can seal off if you go too steep. The flatter the fit you can get that centers well and that has nice peripheral edge alignment, the better off you're going to be later in the day. Now, sometimes you have to go pretty steep on a steeper cornea, but don't just jump to a super steep base curve because you assume it's a post-LASIK ectasia or a steep graft. And this one is kind of like the other one where we're just looking for a few fit abnormalities and then troubleshooting them with base curve. So just like with the PRS, if it doesn't move enough on push-up, you'll flatten the base curve. If it moves too much, you'll steepen the base curve. You will see central bubbles with this lens quite often if you fit it too steep. We don't fill this lens up with saline before we insert it. We just place it right on the eye. If you get a lot of central bubbles that don't go away within about a minute, you fit too steep and you have to flatten that base curve. That's one area you can kind of tell. If you've got a really steep cone, you can't fit it without bubbles. No matter how flat you go, you're really compressing that apex. You probably need to switch to a scleral lens design or something of that nature. because it's just too steep for this lens. But that happens less often than you would think. But watch for air bubbles. Those can be irritating throughout the day. Again, lenses folding up. You see anything that's abnormal, the fit guide is going to tell you exactly which way to move that base curve. We can also change, obviously, center thickness. If you're in the lower center thickness, you can increase it to get more visual stability. And we can also increase the amount of prism to stabilize the lens better. One thing to always watch on this lens, it really does, when you get the fit right, the hash mark, the toric indicator hash mark will usually be really close to, if not at, 6 o'clock. It really does stabilize very effectively with the prism ballast design that they have with this lens. But measure it, and if it's 10 degrees off one way or the other, definitely incorporate that into your prescription with the Lars rule, left add, right subtract. And if you're not comfortable with that, obviously just tell the consultant and they can incorporate that, but that's going to give you your best visual outcome. If your hash mark is greater than 10 degrees moved in either direction, left or right, you need to probably tighten up your base curve a little bit, or increase the diameter, and that's actually up, I believe, in this this fitting nomogram, but you'll increase your diameter to a 15.0 lens if you're not getting good stability, and that usually helps because the fit set all comes with the 14.5. I do end up ordering a lot of 15.0s in this design. I do feel like you get better stability, a little bit better patient comfort. The lenses are a little bit thicker, so you can have a little bit more edge interaction with a 14.5, and I think a 15.0 tends to do pretty darn well. That's all I have. I'm going to let Tony hop back on here. Everybody always likes to ask about pricing with these lenses, and X-Cel has just introduced a new pricing structure for their custom soft lenses, especially the flex lenses that we've talked about here tonight. So I'll let Tony hop back on here and say a few words.
Okay, thanks, Drew. One question I have, and if anybody else has questions, you can type it right into the chat, and then we'll try to take those, but I'll ask a question in the meantime. Drew, just how do you decide when you're going to go to one of these soft lens options? Is it a fine line? Is it I'm going to look at price, or are you talking this over with the patient to see what they might prefer?
Yeah, I mean, you can almost make a decision based on the way that the patient introduces themselves. If they, have struggled with contacts and they're having a hard time and their entering acuity is low, I'm going to a scleral lens. It's the patients who bring it up casually and say, I wouldn't mind contacts. I don't really want to wear them all the time. I had LASIK. I'm happy with it. They're not looking to go back to a full-time contact lens wear and make a huge commitment. That's when I'm going to kind of the PRS lens. Okay. As far as the ARC lens, again, I'm going to go Scleral as my first option. Price is definitely a consideration, but I think, one thing I get a little nervous about is younger kids, mid to late teens, starting to show keratoconus, needing a specialty design, who've never worn a contact before. You can kind of get a good idea if they're going to be comfortable with insertion removal, or if I go to fit a scleral lens and after 10 minutes we haven't gotten the lens in yet. It might be a good time to try one of these designs. But again, the patient's gonna dictate a lot of that based on what they're looking for, and you can lay out the options and kind of let them make a decision.
Okay, thank you. Just getting back to looking at these lenses and the alternatives to a scleral, if you see the pricing structure that we've changed, one of the things that X-Cel, two of the things that we do is we really pride ourselves on education. So we do these webinars to try to educate practitioners on their options, and then we try to be customer friendly. We know that most of the time you are charging your patients by condition. We wanted to make it very simple in this custom lens pricing. And what you can compare it to is if you're using any of these other designs for these irregular corneas, the ARC is comparable to a Kerasoft or a Novacone. Well, the usual pricing structure is you buy a warranted lens and then you can buy 3 discounted lenses for that year supply on a quarterly basis. Well, we give the option to buy any number of lenses, warranted or non-warranted. And where that really helps you is when you get to the end of that year, if you did this as a quarterly modality and the patient's RX has not changed, why do you need to buy another warranted lens? You can simply buy 4 more lenses at the non-warranted price. So we've changed that structure. We leave it up to you on how many lenses you prefer to buy, warranted or non-warranted. It is fully warranted for 120 days, makes it very simple for you. And another thing that we do in that pricing structure that comes along with that warranty is you don't send the lenses back to us. You simply call or email us and say the count number, the invoice number, and the number of lenses, and we credit you, no questions asked. So again, simplified pricing, simplified warranty, easy customer service, and customer friendly. There's no questions at this point, so thank you all for attending. We appreciate you. If you need to contact us, X-Cel Specialty Contacts, you can go through our website and contact us. Thank you very much.
Thanks, guys.